Let's turn back to the intensively treated patient. So you've gotten them through induction and they're in a complete remission. Do you know how much consolidation to give those patients? And how do you determine that? And who would you think about for transplant?
Right. Right. So here's where we need to go back to that information that we collected at the time of diagnosis. This is why it was so important to get that next generation sequencing panel and to know every piece that you can about the underpinnings of their disease and what's making their disease tick, because now is when you need to use that information to make decisions about the next step. And if you didn't get that information at the time of diagnosis, it's gone. So you're going to be trying to do this blindly, which is impossible. So, at our institution, we would assess once a patient is in a remission, what is their fitness for transplant, what are the availability for donors, and, certainly if they have any high-risk features, that would be a patient that we would steer toward a transplant in first remission, assuming they're good candidates for that, for that type of a procedure. The good risk patients, the core binding factor patients, which we should have identified very early because of the data to support use of gemtuzumab at the time of induction, or other patients that we feel have good risk disease biology. Those are patients that we would recommend going on to consolidation. And if they had a gemtuzumab-based regimen, then we would follow the induction plan with incorporating gemtuzumab with the chemotherapy elements for the duration of the consolidation, and that would dictate the number of cycles, et cetera. At least that's how we do things.
So how about using, maybe this is a role for MRD. Should we be, we can't see the disease anymore. Should we use MRD to determine how many cycles?
Well, I think there's a great study from a couple years ago from the Chinese group with patients with core binding factor, AML, doing a very sensitive PCR test for that abnormality after 2 cycles, and then I believe if it was negative, doing a 3rd and final cycle. So yes, I think incorporating MRD into the decision making, not only for how many cycles of consolidation should a patient get, but also more importantly at our institution, if a patient is on track to just receive consolidation with no transplant, but at some predetermined time point still has MRD, we'll take them off that path and back onto a transplant path, regardless of what their upfront disease biology was. If it was quite favorable, but they're proving, in real time to not be having very, very deep responses, then those are patients that probably don't have a chance of being cured with just chemotherapy and should, be reassessed for a transplant.
I think that part of the problem is that there hasn't been really much in terms of prospective studies, and we all have our own preferences in terms of how much consolidation you're going to give them. We have regimens that we give them 6 cycles of consolidation, but there's been some analyses that have shown that 1 cycle of consolidation is enough for most patients. In some of the core binding factor leukemias, perhaps there's a little bit more solid information that they probably benefit from more consolidation, perhaps 4. But that also comes, most of it, from retrospective analysis of 4 versus 1 and things like that. So the evidence is not very strong. Now, you mentioned the MRD and following by MRD, but you could argue that if a patient you've given a couple of cycles of consolidation, induction and consolidation, they still have MRD, is that same consolidation really going to get rid of that MRD, or is it time to change to something else? Now, we talked earlier, we don't have that eraser of blinatumomab or something, so change is fine, but change for what? Yeah. But the point is that, if 2 or 3, if induction and 2 consolidations have not gotten rid of MRD, is that really the answer?
Yeah, I like Dan's approach there. I'm beginning to adopt that as well. That's where I might use MRD, at least for these non-DTA mutations, to decide if the patient should then go on to a transplant. And sometimes patients are just very reluctant to accept transplant first remission. Sure. If you have real data that the disease is still there, that might help.
And then, but then we go back to the argument that sending a patient to a transplant with MRD, a nihilistic person could look at the data there and get very discouraged. And I think that it's a bad predictor for an outcome after a transplant. But what else are you going to do?
Well, and I think we have to differentiate. It is a bad predictor for transplant, but the statistics for transplant look worse in a patient like that the statistics for a patient, but that look better with a transplant than without a transplant.
right.
So in that perspective,
Yes.
that's the best today we
Yes.
can do for a patient.
There is a curative option with that
But there's
plan,
an
yes.
argument to be made from the transplanters that they don't want to transplant that person because they say that that patient is going to relapse
Yeah, I
post-transplant.
mean,
That
but-
unless
but-
they have
yeah.
potentially a myeloablative option, if you don't do a fully myeloablative transplant for that person, the risk of relapse with a reduced intensity or a haplotransplant is going to be extremely high. And they're going to come to me, and they've said this, then they will say, fine, I will transplant your patient as MRD positive. What are you planning to do after transplant? How are we going to maintain that person in a remission? And we do have the luxury, I think, in some cases to have targetable mutations, which I would advocate that we always recheck the FLT3 and the IDH1 and IDH2 at relapse, because there is a percentage of patients for which we didn't detect it at diagnosis, either because it was subclonal at a very low VAF or something, because we have the option sometimes, and there are ongoing studies looking at FLT3 inhibitors and IDH1, IDH2 inhibitors post-transplant. But I think that puts us in a difficult position, because you're going to say, okay, well, the transplanters will say, well, I don't know if I want to take them. And they said, okay, I will prepare your patient for transplant. But what are you going to do in the 6 to 8 weeks in between to prevent that patient from progressing? And what are you going to do afterwards? And I think that makes us all uncomfortable. And again, I don't know that we have an answer to that,
Well,
but
it's
it
a
is an
clinical
ongoing
trials question.
discussion.
It really
Yeah.
is, yeah.
And there are trials. One example I can think of is the BMT-CTN 1506 study, which is looking at the addition of gilteritinib post-transplant, but not enrolling patients post-transplant, enrolling them pre-transplant, so that you can figure out, is MRD going into transplant, what predicts who needs that kind of a
That's
drug.
the way to do that type of study.
Yeah.
That's the important
But I
piece of
think that,
information.
that brings up the question, yes, gilteritinib is not approved in post-transplant setting, but there are off-label FLT3 inhibitors. And there is data, even in a randomized phase 2 study, but there is data that even off-label FLT3 inhibitors could have positive effects, specifically sorafenib. So the argument I get when I try to put my patient on that type of gilteritinib versus placebo trial is, well, I don't feel comfortable with that. My patient has MRD positivity. I would like them to get a FLT3 inhibitor based mostly on a gut feeling, or on maybe the data with pH-positive ALL, where we do put patients on TKI post-transplant. So I think those are difficult things that we're really struggling with. I think the MRD has been valuable, but it's kind of opened up more therapeutic dilemmas now that we didn't have before.